everyone watching this later on YouTube or Roku. I'm honored to be here. My name is Rus Korets, and I'm the Associate Program Director at Beth Israel Deaconess Medical Center Urology Program. I think this is a great initiative by the section, and I hope it continues for many years. Thank you also to George and other organizers for inviting me to give this talk. So today, we're going to talk about evidence-based approach for management of upper urinary tract stones. We'll talk about the role of observation and some atypical scenarios, such as stones during pregnancy. And I think for the most part, thinking about the stone treatment on the broad level, it's a simple issue. There's a stone, and you have a number of Death Star equivalents, so the stone goes kapoof. But we know in reality, surgical treatment of kidney stones is complex, as there are multiple competitive treatment modalities, and in certain cases, more than one modality may be appropriate. Proper treatment selection, which is directed by patient and stone-specific factors, remains the greatest predictor of successful outcomes. Okay, so let's first define our treatment options. We have shockwave lithotripsy, ureteroscopy, percutaneous nephrolithotomy, and open surgery. So starting with shockwave lithotripsy. So how do shockwaves actually break up stones? Living tissue is elastic and for short periods of time can allow passage of high pressures. Stone, on the other hand, are hard and inelastic and thus are vulnerable to high energy waves. So a shock wave is a short duration acoustic pressure wave that has a positive and negative part that can act in different ways. The positive part, or compressive phase, causes a sharp focused burst of energy anywhere from 30 to 100 megapascals, which is then followed by a negative phase or tensile phase. So you start with this explosive process that then expands faster than the speed of sound. This discharge that originates at F1 generates a shock wave that can then be reflected toward the target, or F2. So the primary shock wave is a spherically expanding wave which propagates with the speed of sound into the surrounding medium, and then the energy is dissipated by expansion. It is then focused onto the target stone for fragmentation. So there's been a lot of work that's been done to better define the mechanisms of stone fragmentation. These mechanisms include tear and share, spallation, cavitation, squeezing, and dynamic fatigue. And while you probably don't need to know what each of them is, try to at least remember these words in case they appear on your in-service exam. There are three different classes of lithotripters. The original lithotripter, designed by Dornier, or HM3, was electrohydraulic. So shock waves, which are these blue arrows, are generated by the ignition of a spark plug located in the center of a water-filled ellipsoid reflector. This rapid vaporization of surrounding water generates a spherical shock waves that are then reflected off the ellipsoid and focused on the kidney stones that's located at focal point F2. Piezoelectric lithotripters produce shock waves with the use of a spherical dish that contains an array of small ceramic elements. In response to a high voltage pulse, these elements rapidly expand, generating shock wave, and these shock waves converge on the stone at the center of the radius of the curvature. In the electromagnetic lithotripter, shock waves are produced by the movement of the metallic coil driven by electromagnetic signal. Waves are then focused by an acoustic lens into the kidney. Electromagnetic generators are probably the most common lithotripters used clinically today. They are less painful because they have a wider area of shock wave entry to the body, and the newer generation of lithotripters may develop higher energy over a smaller focal zone. However, as a result, this may lead to higher rates of subcapsular hematomas and may be harder to target smaller stones due to a smaller focal zone. Shockwave lithotripsy is by far the least invasive and easiest to tolerate out of all treatments. Its success is limited by location, stone size, and composition. So in addition to stone characteristics, body habitus is an important factor to consider. There are two studies, one by Gain Farik from Brown and True from Columbia, that examined skin to stone distance as measured by non-contrast CT scan. Both studies found that distance greater than 10 centimeters was associated with reduced success of shockwave lithotripsy, likely due to decrease in shockwave amplitude, meaning less energy that's being delivered to the focal point. Building on this concept, the group from Brown developed the triple D score that was calculated for each targeted stone based on whether the measured stone volume, density, and skin to stone distance were less than the cutoff value, generating a score of 0, 1, and 2. So a triple D score of 0 correlated with a stone free rate of 21%, Score of 1 correlated with stone-free rate of 41%, and a score of 3, meaning you had 3 favorable characteristics, correlated with a stone-free rate of greater than 90%. Anatomic variations within the pelvic calyceal anatomy may also affect the efficacy of shockwave lithotripsy. And this makes sense and explains why in some patients, efficacy of lower pole fragment clearance is worse than in others. So when you think about it, if you have fragments, if they're located in the lower pole, they need to come up before they come down if the infundibular pelvic angle is quite steep. So features of the anatomy that may enhance passage of fragments include the infundibular pelvic angle of greater than 70 degrees and infundibular canals that are probably shorter and wider. A number of other factors should make you think twice regarding using as well as the initial modality. For example, presence of renal anomalies such as horseshoe kidney, calyceal diverticuli, renal ectopy, or significant hydronephrosis can all reduce stone-free rates with shockwave lithotripsy, mainly because of increased difficulty with stone fragment clearance. One of the main drawbacks of ESWAL is its inability to fragment certain types of stone, with subtypes of stones, specifically cystine stones and brushite stones, being the most resistant to treatment by shockwaves. Another important parameter that has significant impact on ESWAL outcomes is the rate at which shockwaves are delivered. So do you want to deliver fast, precise punches or slow, steady hits? And this was answered by a meta-analysis that looked at 9 randomized control trials with over 1,500 cases comparing treatment shocks given at 60, 90, and 120 shocks waves per minute. The overall success rate and success rate for large stones was significantly worse in the faster group, the 120 shocks per minute, compared to groups that had treatments with 60 and 90 shocks per minute. However, outcomes were similar between 90 and 60 shockwaves per minute groups. So in summary, the slow and steady way is probably better. Slower rate is better for stones greater than a centimeter, but may not matter for smaller stones. Lastly, how the gel is applied can have a significant impact on the energy delivered. If there are air pockets between the treatment head and the skin that cover just 2% of the coupling area, stone fragmentation efficiency decreases by 20 to 40%. If 5% of the treatment head is covered by air, this reduces fragmentation efficiency by 50%. So the best technique for gel application is to dispense a large volume of gel directly from the jug onto the lithotripsy treatment head, as opposed to using a gel application by hand, which can mix in air particles into the junction. For this reason, some of the newer lithotripters incorporate a camera that allows you to monitor coupling and assess for presence of air bubbles. So who should not undergo shockwave lithotripsy? So patients with bleeding diathesis or those on anticoagulants, although probably aspirin may be okay. Pregnant women, due to risk of fetal damage, as well as patients with active UTIs or distal obstruction. So moving on to ureteroscopy. As this is probably one of the most commonly used modalities to treat stones, I don't want to spend too much time on this other than to mention that there has been significant evolution in decreasing the size of the ureteroscopes and improving the video quality, with some of the newer digital scopes providing really beautiful high definition images. The downside to flexible scopes is that they are less durable than semi-rigid scopes, and there's been an emerging market over the last few years in single-use scopes which provide a good image and straight out of the box excellent handling. The expense and the environmental impact are still being assessed, but may show comparability. The predominant method of lithotripsy with ureteroscopy is through laser energy. So I'm going to spend a minute just talking about laser energy basics. Pulse energy is the amount of energy that's delivered and measured in joules. Frequency is the number of pulses emitted from the laser fiber per second. And the total power is the pulse energy multiplied by frequency measured in watts. Some of the newer lasers have the ability to not only increase the power delivery up to 100 or 120 watts, but can also modulate the pulse width, which may be advantageous for certain types of lithotripsy. So adjusting these laser settings based on the durability of the stone allows you to control how fragmentation occurs. So dusting refers to the creation of these minute fragments by working the edge of the stone with low energy and high frequency, as well as long pulse width settings. Whereas fragmentation means using higher energy and lower frequency which allows you to debulk the stone into fragments, which may then be broken down further for extraction. Popcorning is a combination of these two modalities, with energy settings somewhere around 0.5 joules and frequency between 50 and 80 hertz, that allows you to decrease the size of the 3 to 4 millimeter fragments that may be to a small enough size that they can be passed. A new player in laser technology arena is the thulium laser, which offers several advantages over the holmium laser. Because the energy delivery is more efficient than holmium laser, it can generate high power output and higher frequency up to 2000 hertz without generating significant heat dissipation. So these are the side-by-side comparisons of holmium and thulium lasers, with integration of smaller fibers and lower pulse energy as low as 0.25 joules, and super high pulse repetition rates up to 2000 hertz, probably results in smaller fragments that may lead to improved stone free rates. I think the evidence is not out completely whether this will become the new standard in laser lithotripsy, but it's certainly the newest and exciting development in laser devices. So moving from laser to the next surgical modality, let's talk about indications for PCNL. And predominantly, it's meant for efficient removal of larger or staghorn renal stones, as well as for treatments of stones in locations where other modalities have failed or may be less effective. So for a typical procedure, percutaneous renal access is established using fluoroscopy or ultrasonic guided puncture. Guide wire is then passed into the kidney and ideally down the ureter into the bladder for a more secure access. Balloon dilator is introduced into the kidney, and then sheath is passed over the balloon to establish a percutaneous tract from the renal collecting system. A rigid nephroscope along with an ultrasound pneumatic or combination probe is used to fracture the stones and suck out the fragments. The resultant fragments may migrate to areas in the collecting system that can't be safely assessed with rigid nephroscopy. So if not removed, these fragments may become symptomatic and result in future stone events. Therefore, flexible nephroscopy should be a routine part of standard PCNL. In fact, some of the complex stone, simultaneous use of retrograde endoscopy and laser lithotripsy can improve stone clearance by simultaneous lithotripsy and also by passing the flexible ureteroscope in a retrograde fashion to hard-to-reach calyces to assess for any residual fragments. In recent years, further technological modifications have led to miniaturization of instruments, with much smaller access sheets becoming available in an effort to reduce the morbidity associated with PCNL. And to define the nomenclature, standard PCNL is defined as a tract size over 24 French. A mini PCNL is defined as a nephroscope with a tract size, with an access sheet size between 14 and 22 French. And ultra mini means a tract size between 11 and 13 French. So specifically for mini PCNL, it consists of a reusable metal access sheath between 14 and 22 French, for which a 12 French nephroscope is inserted. And in this procedure, given the size of the instruments and the smaller size of the working channel, the energy source is often either the holmium or the thulium laser, which is used for stone fragmentation and direct vision. The introduction of these miniaturized instruments has undoubtedly bridged the gap between ureteroscopy and PCNL for some of the medium-sized stones. Now, stone fragments that are created are flushed out using a vortex effect seen here. So this decrease in the cross-section of the tube that leads to acceleration of flow and drop in fluid pressure, which is defined by the Bernoulli principle. And then stone fragments are attracted to the tip of the nephroscope and can be simply walked out or pulled out. And this combination of effective active extraction of stone fragments, along with decreased morbidity from smaller renal puncture, has shown advantages of mini PCNL with regards to stone-free rate compared to ureteroscopy. Additionally, with significant advantage seen for clearance of lower pole stones. So this is something to keep in mind, especially for cases where optimizing stone clearance is important, such as for cases of infection stones. And lastly, what about the role of traditional open surgery? And I would go as far as saying that it has virtually no role in developed countries where access to contemporary endourologic and laparoscopic techniques are available. Even the MIS approaches, which can decrease morbidity compared to open surgery, only represent less than 1% of upper urinary tract stone procedures being performed. One area where laparoscopic or robotic stone removal offers an advantage over standard PCNL or ureteroscopy is in patients with stones as well as anatomic defects that require reconstruction, such as those with concomitant UPJ obstruction or ureteral stricture. So over the remaining time, I want to review a guidelines-based approach and include some of the recent literature. So the most recent guidelines were published in 2016 and were performed via systematic review of over 1,900 articles over a 30-year period. The panel included 2 members of the New England section, Caleb Nelson and Vernon Pays as co-authors, as well as David Wong, Jessica Mandeville, and George Haleblian being involved in the review process. Okay, so let's talk about diagnostic evaluation. Non-contrast CT imaging is the most sensitive and specific imaging modality for the diagnosis of upper urinary tract stones and is still considered the gold standard. It provides rapid, detailed anatomic data about stone burden, location, as well as some of the perinephric findings that may signal extravasation, stranding, infection. It's also recommended in all patients undergoing PCNL to help assess the stone burden and to evaluate for any overlying viscera that may affect the decision about which percutaneous tract is chosen. Additionally, it provides information that can influence the decision about which modality of measurement by capturing stone density, skin to stone distance, and anatomic alterations. Low-dose CT protocols can allow you to perform the study with significant reduction in radiation. The caveat, however, is that its utility suffers in patients with BMI greater than 30. There are some rare situations where obtaining contrast imaging with urographic phase is helpful in determining the best approach to treatment. The situations in which complex urinary tract anatomy may require further imaging includes ectopic kidneys or horseshoe kidneys, other congenital conditions like UPJ obstruction, duplicated collecting system, calyceal diverticulum, or presence or concern for ureteral stricture, as well as patients who may have a renal transplant or prior open surgery. For example, in cases of Staghorn calculi, it's helpful to have a urographic phase to understand the 3D relationship between the stone and the collecting system to help plan your access and to understand where all the stones are located and helping to treat the stones. Other imaging modalities include renal ultrasound, which can provide information about stone size and can have a dynamic component of being evaluated being able to evaluate for obstruction. It's the study of choice in pregnant women, as well as children, and it's being used more and more as the initial evaluation in patients presenting with acute renal colic to the emergency room. The disadvantage is that it's not great for ureteral stones, and visibility worsens in obese patients. KUB allows for visualization of radiopaque stones and has poor sensitivity for stones overlying the bony pelvis. You're also not able to visualize radiolucent stones like uric acid stones. Additionally, it provides no information on the collecting system anatomy unless it's combined with intravenous contrast, which can be performed in a trauma setting using for you to get an on-the-table IVP. So moving on to management strategies for ureteral stones. So this is a guidelines-based algorithm for patients with ureteral stones. Looking at complicated ureteral obstruction. So although individuals with symptomatic kidney stones will present to the emergency room for their initial care, only a small percentage will actually need to have an emergent intervention. Most patients treated for a kidney stone in the ER will be discharged home. However, when emergency intervention is required, it may literally be a life-saving procedure, as in the case of obstructive pyelonephritis. So in this study by Mike Borofsky, looking at outcomes of patients presenting with obstructing calculi and infection, decompression with a stent or an nephrostomy tube was associated with more than 2-fold reduction in mortality. Additionally, not only is decompression important, but the time to decompression is also a significant predictor of mortality. After controlling for patient demographics, comorbidity, and disease severity, in this study by Chris Haas and Oja Shah, delayed decompression significantly increased the odds of in-hospital mortality by 29%. Other reasons for acute intervention include worsening renal function, bilateral obstruction, patients with a solitary kidney obstruction, as well as intractable pain. So in terms of my thinking of a stent may be preferable in cases of small distal stones, if there's a low risk of impaction, if patient is stable, or the likelihood of future surgery is high, and frankly, if the OR is available and ready to go. Nephrostomy may be a better alternative in cases of large proximal ureteral stones where there may be a higher likelihood of stone being impacted. Also, if the patient's unstable on pressors, or if you suspect that there's a concomitant anatomic abnormality, whereas a nephrostomy tube will allow you to better evaluate for obstruction with an antegrade study later on, whereas while a stent may confuse the picture. So what about uncomplicated ureteral stones? For patients with ureteral stones less than 10 millimeters, guidelines recommend a trial of observation with medical expulsive therapy. And this would consist of hydration, pain control, preferably with NSAIDs if renal function is not compromised. What about the role of alpha blockers? There's been some controversy in the endourology literature on whether MET and addition of alpha blockers actually improves passage rates, stone passage rates. A recent meta-analysis have shown that for stones between 5 and 10 millimeters, this inexpensive, low-risk medication has potential to benefit patients with less pain, shorter time to stone passage, and decreased likelihood of subsequent intervention, and at worst, do nothing. For patients undergoing a trial of ureteral stone passage, clinicians should offer repeat imaging prior to stone intervention, especially if symptoms have changed. Repeat imaging can include KUB, renal bladder ultrasound, or CT, and if it's a distal ureteral stone, you can just get a pelvic CT to lower radiation exposure. In this study by Brian Eisen's group, if patients' pain resolved, but they have not seen the stone pass, 26% still harbored a stone, underscoring the importance of imaging. Seeing this change in ureteral stone position may also affect the decision to change intervention modality, i.e. moving from shockwave lithotripsy to ureteroscopy if a stone has moved from the proximal ureter to the mid-ureter overlying bony pelvis, or to defer intervention if the stone has advanced to the distal ureter and continued observation is reasonable. Intervention can be considered if the stone fails to pass over 4 to 6 weeks, or sooner if the patient has persistent or worsening pain or has multiple ER visits. So who may be offered treatment sooner? This is data from a multi-center burst collaboration in Britain of over 2,500 patients with acute ureteral colic who were discharged from the ER with initial conservative management. Stone size and composition were the most important determinants of the need for active stone treatments as stratified by location of initial stone and its size. So this may be quite helpful in counseling patients on their success with MET. And you may be identify patients who may be all offered earlier intervention. So moving to treatments, if you look at guidelines overall, there's been a swing towards ureteroscopy and away from shockwave lithotripsy in management of ureteral stones. And this is based on the stone-free rates. So in patients with mid or distal ureteral stones who require intervention, who are not candidates or those who failed MET, ureteroscopy can be offered as first-line therapy. For patients who decline ureteroscopy, clinicians may offer shockwave lithotripsy. And this is evidenced by the fact that ureteroscopy is associated with significantly higher stone-free rates in a single procedure compared to shockwave lithotripsy. And the disparity in stone-free rate outcomes was particularly notable for patients with less than 10 millimeter mid and distal ureteral stones. So in my practice, I have a discussion with patients about shockwave lithotripsy and ureteroscopy, taking into consideration the increased invasiveness of ureteroscopy, as well as the risk of requiring a stent, but offering a higher success rate of being stone-free, especially for stones that are over 1 centimeter or in the mid or distal ureter. For lower and mid-ureteral stones, semi-rigid ureteroscope is my go-to instrument because it allows you increased control and smaller overall caliber of the scope at the distal tip compared to a flexible ureteroscope. For proximal ureteral stones, a flexible ureteroscope is preferred, especially in taller male patients where you may not be able to reach the stone with a semi-rigid scope. What about ureteral stents? So we know that stents are generally associated with significant lower urinary tract symptoms, worse quality of life scores, and so routine stenting is not recommended as part of shockwave lithotripsy. What about afterwards? A meta-analysis of 8 studies showed there was no significant difference in stone-free rates between pre-stented patients compared to those who did not have a stent. But not only was there no difference in outcomes, there's also no difference between the groups in terms of fevers, UTIs, or need for additional procedures. Finally, there's also thought that presence of a stent can prevent fragments from passing through the ureter. Following ureteroscopy, stents may be omitted in patients meeting all the following criteria: those without suspected ureteric injury, those without evidence of ureteral stricture or other anatomic impediments to stone fragment clearance, and those with a normal contralateral kidney, as well as those with without renal functional compromise. In some patients with large or complex ureteral stone burden, neither ureteroscopy nor shockwave lithotripsy are likely to accomplish stone clearance in a reasonable number of procedures. In such cases, alternative approaches may be considered. So percutaneous antegrade ureteroscopy may allow for more expeditious stone clearance, as larger and more efficient instrumentation can be used, removing larger pieces in a more effective manner. Additionally, patients with anatomic abnormality, especially patients with urinary diversion, may be more effectively treated through an antegrade approach. Okay, so again, this is the algorithm for ureteral stones. If you want to take a screenshot. All right, moving on to renal stones. So management consideration need to take into account size, location, composition, and anatomic factors. So this is a simple algorithm to help you think through the treatments. So starting with the easiest stones to treat, the renal stones over 2 centimeters or Staghorn stones. PCNL should be offered as first-line therapy for these patients because it offers higher stone-free rates than shockwave lithotripsy or ureteroscopy and is less invasive than laparoscopic or robotic-assisted procedures. Compared to ureteroscopy or shockwaves, the success rates of PCNL is also less affected by stone composition, stone density, and location. And we know from multiple trials that effectiveness of shockwave lithotripsy starts to suffer as you get to stones larger than 2 centimeters, with a higher likelihood of retreatment or additional procedures. Similarly, in a randomized trial comparing ureteroscopy and PCNL, stone-free rates were significantly higher with shorter OR time in favor of PCNL. What about location? Where the stone is located within the kidney is also extremely important. In the lower pole 1 study, which was a prospective randomized study comparing the effectiveness of shockwave lithotripsy to PCNL, the stone-free rate of shockwave lithotripsy dropped to 37% for stones over 1 centimeter that were treated with shockwaves compared to 85% for those treated with PCNL. In a follow-up lower pole 2 study that compared outcomes of shockwave lithotripsy to ureteroscopy for treatments of lower pole stones less than 10 millimeters, ureteroscopy was associated with higher stone-free rates, 50 versus 35%, and a lower reintervention rate. And this makes sense that if you take into account the pelvic calyceal anatomy, which may affect the efficacy of treatments, so that the fragments have to be expelled across unfavorable anatomy, it's going to be harder to clear stone fragments with shockwaves. Interestingly, 90% of patients treated with shockwave lithotripsy reported they would have this procedure again, compared to only 63% of patients treated with ureteroscopy, highlighting the less invasive and better tolerability of this modality. Recent studies have also demonstrated that procedures with lower stone-free rates that lead to residual fragments following treatments are not clinically insignificant. Andy Portis has shown that for patients with residual fragments, overall, 29% of patients required intervention for these fragments. The larger the stone fragment, the higher the rate of stone growth, complications, and eventual reintervention, with nearly a 50% repeat surgery rate in patients with residual fragments greater than 4 millimeters. Additionally, in patients with known or suspected infection stones, significant effort should be made to remove residual fragments to lower the risk of subsequent infection and further stone growth. So for lower pole stones less than 10 millimeters, clinicians may offer either shockwave lithotripsy and ureteroscopy, while for stones more than 1 centimeter, ureteroscopy or PCNL are appropriate options. And I don't know about the other faculty in the audience, but I will typically discuss both options with patients. But for those with suspected infection stones, I think access to a mini PCNL set may really lessen the gap between the morbidities of these two approaches. Stage ureteroscopy is also appropriate for patients who are not candidates or refuse PCNL, such as patients with uncorrected coagulopathy. So what about asymptomatic stones? We know that detection of asymptomatic stones has increased mainly due to increased utilization of CT imaging. So from the department of it's hard to make someone who feels fine feel better, observation of asymptomatic non-obstructing calyceal stones is appropriate as long as patients are counseled about the risk of stone growth, passage, and risk of pain in the future. Several studies have evaluated the risk of progression, which is defined as symptomatic stone event, stone growth, or need for intervention, with somewhere between a 15 to 40% rate of developing a symptomatic event within 4 to 5 years. With stone growth seen in about a third of cases, and need for surgical intervention in about 7 to 26% of patients. So taken collectively, this suggests that up to 50% of asymptomatic stones will progress, but a much smaller percentage will require surgical intervention, and consideration for active surveillance of these stones should be taken into account. Follow-up may consist of a physical exam and re-imaging to assess for stone growth, with consideration of medical therapy or dietary modification if growth is seen. There are certain settings for which treatment of asymptomatic, non-obstructing calyceal stones may be more appropriate than observation. So treatment should be considered in patients with associated urinary tract infections, patients with solitary kidneys, children, certain professions such as pilots, and those with poor access to modern medical care, as well as women who may be considering pregnancy. Okay, let's lastly talk about urolithiasis in pregnancy. In a study that came out last month examining a large national claims-based database, the incidence of symptomatic urolithiasis during pregnancy was 8 per 1,000 pregnancies. It most often occurred in the second and third trimester in terms of timing. This rate is no different than in non-pregnant women of childbearing age, but pregnancy adds some unique restrictions in both diagnostic modalities and treatment options that are available. Interestingly, 75% of these patients were first-time stone formers, and in the good news department, 70 to 80% of patients were able to pass the stone spontaneously without a surgical intervention. Renal ultrasound is considered the first line of imaging to perform in pregnant patients, with a varying sensitivity from 40 to over 90%. It's favorable because it's cheaper compared to other modalities, it's widely available, and there's no ionizing radiation. It is limited by body habitus and cannot differentiate physiologic hydronephrosis, which occurs in about 90% of pregnant patients, from pathologic hydro. And although ultrasound has a variable and somewhat limited sensitivity, the addition of looking for ureteral jets to assess for obstruction, or measuring resistive indices, or using a transvaginal ultrasound to image the distal ureter have been shown to increase the diagnostic accuracy of this modality. MRI without contrast is safe and effective and is now considered the second-line modality during pregnancy. Now, although MRI does not visualize ureteral calculi directly, stones appear as signal voids overlying a high field of signal that's seen in T2-weighted images that are associated with hydronephrosis. Or you may see a double kink sign in an area where the stone may be impacted and causing a slight kink in the ureter. The spontaneous passage rates for pregnant women with ureteral stones have not been demonstrated to be different than those in non-pregnant patients. Therefore, in patients whose symptoms are controlled, a period of observation should be the initial therapy. The question of alpha blockers as part of MAT has not been very well studied, with one study looking at about 20 pregnant women with documented renal ureteral calculi and showing that tamsulosin was safe for the mother and the fetus, and that it may ultimately be helpful as an adjunctive therapy for symptomatic pregnant patients. However, until a conclusion is reached, the ultimate decision regarding medical and surgical management should be based on a discussion that includes the patient and her obstetrician and is recommended by the AUA guidelines. Now, NSAIDs should be avoided due to risk of pulmonary hypertension and risk of premature closure of the fetal ductus arteriosus. And beyond conservative management, up to a third of these patients will still require some kind of intervention. The indications are generally the same as for non-pregnant patients, including pain, nausea, vomiting, signs of infection, or complete obstruction, with the addition of obstetric complications such as preeclampsia. The main options for surgical treatments are to temporarily relieve obstruction with either ureteral stent or nephrostomy tube. Now, when these interventions are deployed, there is a need to exchange either stent or nephrostomy tube every 6 weeks due to risk of incrustation. Ureteroscopy with stone removal has been shown to be safe and highly effective in pregnancy and should be done under either strict ultrasound guidance with no fluoroscopy or with just minimal spot images. A review by Simmons that looked at 108 pregnant patients who underwent ureteroscopy showed that the overall urologic complication rate of this modality in pregnant women was about 8.3%, with no significant difference between the rates of uterine injury or UTI rates compared to non-pregnant patients. Another study looking specifically at post-ureteroscopy obstetric outcomes, they identified 2 complications out of 46 pregnant patients treated with ureteroscopy for an overall obstetric complication rate of 4.3%. So despite similar complication rates, the acuity of complications in the pregnant patient is higher than non-pregnant patients, given the risks to the fetus, underscoring really the importance of a team-based approach. The ACOG guidelines also recommend that for any non-urgent surgery, such as ureteroscopy, be performed in the second trimester to minimize the risk of preterm contractions or spontaneous abortion. So in summary, we have recently published guidelines to improve stone management that acknowledge evidence-based practice as well as shared decision-making. There's been technological advances over the last several years that continue to improve in terms of equipment, as well as better understanding of how to minimize complications of PCNL, and that have brought really these both laser uteroscopy and PCNL to the forefront of surgical stone management. So thank you for your attention, and I'll take this time now to answer your questions. All right. So the first question is commenting on infection and complication rate of percutaneous nephrostomy during pregnancy. And does this increase pregnancy loss versus stenting? So any infection, whether it's urinary tract infection, increases the risk of spontaneous abortion during the first trimester, as well as risk of PPROM or premature rupture of membranes in the second and third trimester. Now, there's been no studies to my knowledge looking at differences in complication rates with stent versus nephrostomy tubes, as both are indwelling tubes and both will require for patients to be placed on prophylactic antibiotics based on ACOG guidelines. The thought is with that if the infection or the stone is found early in the pregnancy, a nephrostomy tube may be better as it requires less radiation and can be exchanged just under local anesthesia compared to stenting, which does require general anesthesia. Additionally, if patients have symptomatic infections during the first trimester, it may be better to wait until second trimester and then provide definitive management of the stone. All right. Well, my email are here, so feel free to reach out with any questions. And thank you for your attention.
Thank you.